looking at the canine, if I feel the enamel, it seems to stop right at the gingival margin. There's some enamel underneath the lateral aspect, and we'll have to see if there's anything under there that may be a real limiting factor. This tooth has lost some of its incisal edge, but it's very round looking now, and it'd be nice if there was something that we could do to extend it. I just can't tell for sure. The other limiting factor is the next tooth, distal, the first premolar, has a crown, and the one, as we go successfully back, each one is crowned, so we don't want to expose those margins. The central incisor, which is our chief concern, we'd like to gain about 1.5 millimeters to make it level with where we expect to bring the margin of the pontic. So if I feel under the central incisor margin, it feels like there is enamel, and of course it's a little bit less of a concern because it will be a crown. So we can gain what we need to on the central. We just don't want to enter this area where the ridge defect exists because we'll be doing an augmentation of that site at the same surgical procedure. So we'll start by lengthening the right central and gain something that looks relatively ideal and looks like it would match the left central. So we'll begin again with crown lengthening for the right side to the extent we're able to. Limitations again on the canine principally. When that's complete, we'll do a single tooth ridge augmentation with alloderm for the left central incisor. So we'll begin now. Let's see if we can leave these in place. In fact, let me see the probe again just for a moment. Yeah, if we probe this, and tell me at any time if anything disturbs you, if we can make anything more comfortable. If we probe in the sulcus again, about 1.5 millimeters is what I'd like to gain. And I should show you too that the zone of keratinized tissue is between 4.5 and 5 millimeters. So we're able to make a 1.5 millimeter collar without a problem. Currently, I think the question came up about the length of this tooth. It measures about 9.5 at this time, and its width is about 9. So we can extend it to about 11, and 11 by 9 gives us a nice ratio. The adjacent tooth currently is about 11, and I don't know that we can shorten it much, but we just want to bring this tissue margin forward where it has the loss of ridge form in the current concavity facial to that pontic. So our initial goal will be to gain about 1.5 millimeters, and we can look at this and see that that's about to this point. We can almost see a mark on the tissue, or you can mark it with a little horizontal line like that, or with a little vertical line like this, pressing the probe into the tissue and leaving a small mark. Now if you'll lean down for me just a bit, and I think you can see that mark now. And we'll be using a 15 blade and making a contour. And let me show you a couple of other features just to be complete here. You remember that this embrasure was opened, so there is quite a bit of space here right now. We need to be careful about this space. We don't want this to increase. There was a question about probing depth. The probing depth is all within normal limits. All the probings were 2 to 3 millimeters, and we can show you the radiographs and show you there's no loss of bone. Principal concern, I think, was this site, and that's measuring about 1.5 to 2. So this papilla actually may be able to fill to a degree if we gain support from the pontic and, of course, lift a bit beneath it. So probing depths are within normal range. There's no significant loss of bone. So now then we will make this first incision, and it will be away from the papilla. We want to create about 1.5 millimeters collar. I'm trying to stay where I can show this to you. And I'm going to come back to the mesial aspect. And that angle is about 45 degrees. And now we've excised that collar, and you see that there's really pretty much enamel visible. So we can make a nicer length width ratio for this tooth. I will gain this more specifically with the bone contouring. So the question became earlier about the position of the bone. And if this is 11 millimeters from the edge to the desired soft tissue margin, then the bone will be an additional 3 millimeters. So it would be 11 plus 3 to reach that point. I'm going to look at the canine, and I really think we have little to gain here. So to be safe with the canine, I simply will do an intracellular incision. And in case we end up in that exact location, I'm going to go ahead with the contouring of the lateral. And if I use a probe to give myself a line between the between the central and the canine, I can see that's the maximum distance I'd want to go to raise that lateral. This lateral is relatively narrow, so I don't want to go up much. But at this point, it has a relatively flat contour as well. So I'm going to simply take a small collar to improve its contour and try to give it a little bit more pleasing appearance. So I'm going to take about a millimeter collar. So we take a small collar. Again, about a millimeter, then an intracellular incision to lift that tissue. And we have just a little bit more pleasing contour. Lean down just a touch for me, and perhaps that shows a little bit better that way. So again, very subtle changes. And the next incision will be the canine. I'm just concerned about the midpoint here, but I will make just a slight collar on the distal, about a half a millimeter, to broaden that just ever so slightly, and otherwise stay intracellular. And then I'm going to go ahead and release the papilla. So this incision is to give me a papilla that has a thickness relatively equal to that of the facial tissue. I will not extend that to the distal papilla. I will, if anything, I'll tunnel that area. And now I will do the same thing with the papilla between the lateral and the central. Remember, this was the papilla that was blunted. So I'm just creating a little bit of a superficial layer that has the interdental tissue remaining between the teeth from proximal line angles back. And I'll just check this incision, make sure that it is to the crest, blocking or not. So the contouring is complete. And now we'll lift this as a mucoperiosteal full thickness flap with the Boozer elevator. And this is done as full thickness because we intend to just replace this flap. We're not coronally advancing it, so it's very different from the flaps that we do for, or the preparations that we do for grafting. I'm trying to confine this reflection at the midline so that I preserve the site for the augmentation that will follow. This is going to be I'm sorry to say, a little bit of peekaboo for the osseous part, because it's just not going to be extremely visible. The contouring will be a little trickier than the normal case. I'm going to switch now to the micro elevator, because I want to go underneath some of these tight areas, and the booster elevator is just a little bit large. This is a Hugh Freedy instrument that I may have mentioned. We use it principally in the root coverage procedures. Still have good visibility. So I'm just working around this canine, getting a little past the distal aspect, and see if that gives me a view. And let me go back to Boozer for a moment. And you still see me there now? See the fields? I'm just using a 15 just to refine some of that soft tissue. And you can see the osseous a little bit better, I think. I think one thing that might be pretty interesting here is the relationship of the restoration margin to the bone crest. So we'll measure interproximally here, and we find it's right at 3 millimeters. And that's a little bit close, just right at 3. At the midline, it's going to be right at 3 also. And if we measure the bone crest here in the mid-root area, it's about, to the existing crown margin, it's about 4. And we want this to be, if we want this tooth to be 11 millimeters in length, then we're going to need to move about 4.5 millimeters from this margin. And we're maybe 3. I think we need to move about 1 millimeter. The lateral we don't need to move too much. We want to keep it about the same level as the central. So because of this, I'm actually going to start with the, because of the limited access, I should say, I'm going to start with the ocean bean. And this will be the one with a modified handle. So the way I use it is I come down and engage the crest and twist. And perhaps you can see that now. I think that's showing up. And that allows me to get the bevel that you saw. Normally I would do this with the with a round diamond, but we just don't have the access. So I'm trying to get the bevel with the ocean bean, and remove that for just a moment, because I need to bend this tissue. So I'm going under it without showing it to you for the mesial. And just directing this chisel so that it is parallel to the long axis of the tooth or the root, and twisting. And I don't want the lateral incisor any higher than the central, so I've been gentle there. And I think I can reduce that perhaps with a burr. And on the canine, you can see the CEJ is just really coronally positioned. In fact, if you look at the CEJ of the canine relative to the lateral, you see it is more coronally positioned than the lateral. So we just really can't do much with the canine unless it were to be restored. That's not in the plan. To add a crown to that, it certainly could be done. I don't think it's critical. And I'm actually going under the papilla and twisting to get that interdental crest. Go under it this way and twist to bring the crest down, because we had a little bit of a close margin to the crest. That's still showing. And thinning out some of the excess this way as well. The excess thickness. And just making sure it's nice and round on the lateral. It was a little bit peaked. And if we measure, we're approaching the 4.5 millimeters. So that means that really I'm about 3 millimeters from the existing CEJ of the central. That's practically ideal. Interproximally, I need to do just a little more in this corner. So I'm going to do that with a Younger Good 7/8 curette. So I can draw the curette against the osseous tissue, moving it from the facial across the proximal, and reduce the crestal height under that papilla. And then I come back onto the facial aspect and refine that margin. And just as well on the lateral, same movement. Now check that crest area again. And now then I'm going to look under there just a little bit differently. So I'm getting just a look at that crest and thickness of the bone. Actually, you can use the Bouger elevator to do a little bit of the contouring, just refining of thickness. I'm just getting the interproximal thickness and just rolling it in. Again, typically I would use a number 6 diamond for that, just don't have quite enough room. So I'll put this flat back and see with the probe if the margin's at that location. Do I measure 3? And you can see that I do. So we've gained that 1.5 millimeters for the central, and I think we've pretty near achieved what we're after. You can see the CEJ here, that's all enamel. And if we suture that back in that location, I think we have achieved a nice contour. We've gained a 1.5 millimeters. It may be just 0.5 millimeter too much coronal positioning of the osseous crest. We'll just go back with the Younger Good 7/8 curette. And actually I'm going to lift that back again I'm just using a Boozer elevator for retraction. And just take that margin up just another 0.5 millimeter. Then I can use the curette also to thin that, or to bevel that bony margin. And then to give you another peekaboo look at that. And now we'll put the flat back again and use the probe again. And I think we're really close to it. When we put that at 3, I'm displacing it, but that's 3. You can see that now, hitting osseous crest, and we get the 1.5 millimeter gain. So I think we're good with that, and actually we can suture this with the 6/0 chromic gut suture. So what we've done here is a subtle adjustment of the gingival margin between a millimeter for the lateral to 1.5 millimeters for the central by hand instruments without using the diamonds. Normally we would use diamonds, but normally we'd have a greater access. If you had a large amount of osseous to do, you could not do what I've just done, or at least not by the method I did. So I just placed a suture through the papilla about 3 millimeters from the edge. I'm going through the interdental tissue now. Went through the flat papilla first. Shannon captures that on the inside, open just a little bit, with the precision dressing forceps. And we draw that through, and she checks to see that we have a good bite and lets me know. That way we can just do a simple interrupted. But now we're suturing the papilla between the lateral and the canine, so I go through the papilla first, recapture the needle, and then I'll go through the interdental tissue. And see if I can come out right in the middle palatally. And in this case, Shannon indicates I did not capture tissue. That happens sometimes. So I will do a vertical mattress on the palate with a tiny needle. That's a way to ensure that you have, turn toward me just a little bit, that you have a good tissue penetration that will hold the suture, and you don't damage the papilla, the interdental tissue, with a second penetration through it. So I just did a simple vertical mattress, not to change any tissue positioning palatally, but just simply to hold the suture. Then I come back through the interdental space. Shannon captures that with the dressing forceps. And I wet the needle holder in water when using gut suture, so the suture slides off of it easily. And then we just tie that. And you can see the Gain, again, is going to be in the neighborhood of 1.5 millimeters. It's to the CEJ, making that tooth approximately 11 millimeters. It may end up slightly less. It could be 10.5 by a width now of about 9. And the next step then is to augment the ridge area. So in order to do that, we need to remove this fixed prosthesis. And I've, of course, pre-anesthetized premolar through premolar. So if you were worried about that, that's already done. So I'll use a hemostat at the interproximals and just lightly rock. There's a mosquito, curved mosquito hemostat, and that allows us to remove that prosthesis rather easily. And we can visualize the ridge defect. And it's principally buccal, somewhat of a papilla blunting here and here, mostly here. We can lift those a bit, but you see this preparation is very close to the papilla. And if that's been done prior to a ridge augmentation, it will limit how much you can elevate that papilla to a degree. I'm going to just remove the excess cement here. Because we'd like to keep that out of the pouch that we're about to create, and of course don't want it beneath our flat margin. And now then, if we look at this ridge defect, we have a nice view, I think. We see there's a slight depression here, and we want to do a filling out of that site. And we'll do that with a double layer of alloderm. So the method will include application of PRP to the graft, so you'll see that taking place in a moment. And we'll use an incision design that is a crestal incision, curving facially, so it's a semilunar form that is in the same direction as the adjacent sulci. This is not as difficult to visualize here as it can be in some cases where there's a really big dip in the facial dimension. In those cases, you would make the same directional incision, but it would look peculiar. You would want to follow the curve of the defect, which would be concave, or you'd be inclined to do that, but that's not the direction that you should go. So we'll make the surface incision with a 15, and that will be to the osseous crest. And then we'll create a pouch facially. We'll measure that in width and depth. The depth usually is about 8 millimeters. And then we'll make a graft twice that long and fold it to put into that defect and plump it out. So open just a bit. That's good. So we're going to start at ridge crest, the mid crest area, not in the sulcus of the teeth. We want to stay away from the sulcus. So this will be a semilunar incision to the osseous crest. And again, I worked from distal to mesial. And that is the initial incision. I'll use an Orban now to outline that again, see if I can do it without blocking your view. I think the angle lets me do that. And this is a common incision for me for a lot of procedures I do around implants and adjacent edentulous areas. So that is the initial design, and then we do just a sharp dissection. I'm using the Orban again to do that. I'm encountering some scarring from previous surgeries here, so this is not mobilizing really simply, but we'll stay with it for a little bit and gain some movement. Again, this is supraperiosteal dissection, actually going under this papilla. and creating a little bit a broader pouch than the limit of the incision. We need to free this laterally for mobility. Am I blocking that? Sometimes it's necessary to enter the sulcus, and let me point to it. Enter the sulcus here and here if you want to lift those papillae. I don't think we're going to do that here, but I haven't completed the dissection. I'm not getting the mobility yet that I want. I'm starting to now. What I don't want to happen is have this papilla slump. There is some scarring, and that's going to pull on this a little bit. I'm just going under this papilla now. And you can see I'm starting to move this pouch. I'm getting some of the freedom of movement that I had hoped for. And I'll suture against that. I'm not going to denude that. Sometimes if this is a big slope, you actually have to denude the surface here. I don't think we want to do that, because I think we want to try to keep this as far facially as we can, and that little projection of tissue helps do that. I just want to make sure there's no tissue binding this down that keeps it from projecting facially. I run into an osseous projection here, so we don't need to be under that papilla so much, but we want to free this so it moves. I think you see the scarring on the surface here from previous surgery. I'm just trying to make sure that all that scarring is loosened. And that allows that. I think you can see now it really comes buccally quite well. Let's see a Boozer elevator just a minute. We'll use the Boozer to just stretch that. I think it's stretched pretty well. Yeah. But you see how that'll plump out? And that papilla can come up some. So that's the typical site preparation I do for a single tooth soft tissue ridge augmentation. And now we'll prepare the graft. See a probe just a minute and check depth and width, so we know what size graft we want. And we're going to want about 8 millimeters in width, and typically it's going to be at least 8 in depth. I may go a little bit more. It looks like, just feeling that area. Looks like we could pretty much do 11. I just want to check that interior one more time. If we do 11, that means the graft will be 22, and we said 8 in width. So we do 22 and then fold it. And I'm using a 1x4 graft. So this is the alloderm graft from the package. And we can see this side is the reticular side. And if I fold that, I think by contrast you can see that the surface that I folded over is the basement membrane surface. So we will actually place this with the basement membrane surface approximating itself, and we want this then 22 millimeters by 8. So I will trim this to be 22 millimeters. That's 11 by another 11 plus another 11. Just make an incision through that to divide it. And then we want it 8 millimeters in width. So you can do this a number of ways. I like using a 15 blade and a probe, and then the excess we discard. I didn't just put it back in the normal saline, and then I'll use a dry gauze, place the graft on the dry gauze and squeeze it out. And then I'm going to place it in the platelet pour fraction for 2 minutes. So put it in that section and just simply let it absorb the fibrin, fibrinogen that's within this platelet pour fraction. This will help draw in the platelets from the platelet-rich fraction that we put it in next. And just wipe the sides of the dish to remove the excess, and then place that in the platelet-rich fraction and let it soak there for 1 minute. Okay, we have a minute there, so we will remove excess again, and then I'll place this on gauze and just clear the surface. That's the basement membrane side, and that's the reticular side. You can tell the difference. And then we use the activated PRP. This adds the PRP to calcium chloride and thrombin, or vice versa. And we just put a few drops on there. We'll let that set. This may be wiped away when we introduce the graft into the pouch, so we can add some more at the time into the pouch. So it's not absolute which method you use, but we'll see if we can gain some from each. I'm going to fold the graft, and we're losing some of the PRP. The gauze is actually picking it up, but we'll reapply it. It's a little hard to do this method with the PRP and keep it on there. But I want to capture this graft in just a little better grip. And then work it in to this pouch. So just with a little patience, this will work its way in. Switch to elevators just for a moment. And now use the corn pliers again. I'm going to do a little push. And it's starting to work its way in. What you're doing basically is fatiguing the pouch a little bit, and it stretches. So you just want to use patience. And when you're close to getting there and you think you're going to make it, such as right here, this is a good time to place your suture, because you know that you're going to have access to the two ends. This would be a good time to use the microcorn suture plier. Open just a little for me. Good. So I'm going to go to the left-hand side and place this suture through. And I've got one end. It's hard to go through both ends at once, just because of the thickness of the graft and aligning these the suture pliers. But you just need to stabilize the graft to do this. I can get the other side now. And go through the little opening in the suture plier, pull that through, and now we capture the graft, so that's good. It can't disappear now. It's pretty discouraging when it disappears. So we'll pull that through, finish introducing the graft into the pouch, and we're prepared for suturing. So I go back with the elevator and just gently nudge that, and then use the corn suture plier as well and push it. Let's keep my suture visible and the two ends visible, so you see the two ends. And we're just slowly working our way into the pouch, and then all of a sudden you're in. I don't want to be in too tight just yet, and we'll finish the suture. So I'll catch this palatal wall. I've already penetrated the graft. Then we can tie that. Of course, we're using gut suture because this often will be a difficult suture to retrieve, or could be. You don't have to use gut. Tying this a little bit loosely. And now while I can still visualize the graft, I'm going to get the mesial end of it so I can go through the graft, not the facial wall of the pouch. And I should be through both layers. It's not so obvious as the first time when you quite clearly had both layers. I'm going to lightly tie that because I now want to introduce that just a little bit further into the pouch. And now I can finish tying it. And those are the only two sutures that we need. A degree of improvement of that site. The graft is in place. I can push it out a little bit there. But we're going to put the Ponic on. We can try the bridge on and see what this does. This was the provisional that was provided, and that will fill out that buccal deficiency. So that's how it should look when that heals. If you wish, you can put a suture through the facial margin to stabilize that. In this case, I might do it. I usually don't, but I think on this distal corner I will. And we'll use the chromic gut again, but I think I can stabilize that better. And really have something that I like. I'm going to hold the prosthesis on while I put this suture through first. And again, this is creative suturing. You do what you need. And we're going to use the elevator straight end to separate the graft from the wall, pouch wall. And we're exiting now with that suture. And I would go to the palate, do a vertical mattress, and come back, and that will help stabilize that corner. And just make sure that your suture stays free. Good catch through that loop. So vertical mattress palatally, and we'll come back through and tie, and this will be the last suture. And then our last step will be to replace the provisional. We want the provisional to actually touch that graft. I want this suture on the pontic side of the papilla. Now let's slip that bridge off. And I often don't use this suture. Most of the time I don't, but it looked like it would help here, because I want to try to prevent this pouch from moving coronally. I'm sorry, from moving apically. One of those directions. Look at that. We have accomplished part of what we were after in terms of raising the tissue on one central and filling out the ridge defect on the other. I'd like to see the papilla improve between the lateral and the pontic. I think it can secondarily. I think if I try to raise it now, that I run a risk of making it worse. So we don't want to do that. We have pretty good left-right balance. I'd like to have the canine margin higher, but we couldn't do that. But I think we can dramatically improve this ridge area. There's a possibility that we would want to do a secondary procedure to help that papilla, but we expect now that there will be swelling. This should improve actually in appearance with healing time. Okay, the next step, we're going to add PRP to the pouch site because I think we lost it on the graft. So I'm going to come just under the edge of that pouch and also add it at the margin of the crown lengthened area. So we'll let that sit for actually a few minutes, and then we have to clear it from the teeth that will have the bridge replaced.